Okay, so this video is about the medications for bipolar disorder. So the key thing here is to think about three different categories of medications for bipolar disorder. We have lithium, which is pretty much its own category. Then we have anticonvulsants, and we're going to learn about three primary ones that are used, but a lot of different anticonvulsants can be used. And atypical antipsychotics, which are some of our newer antipsychotics. And any of those categories of medications can actually be used as monotherapy at this point. So we're going to start first with lithium, and I know that you've already looked at that on your advanced organizer as well as hopefully through your flashcards. So this likely will be mostly review. I put a lot of this information in your flashcards. So, of course, lithium is a first-line therapy. It is indicated for bipolar disorder alone or with combinations of other medications, and it should not really be used in pregnancy. And also, it can cause thyroid or renal dysfunction. So, those people that already have dysfunction should not be taking it either. Another key, very similar with what we talked about with children, is that antidepressants should not be started until the person is on and stabilized on a mood stabilizer. An antidepressant could, in some circumstances, push somebody into a manic episode. So we do want to be careful with that and ensure that our patients are on a mood stabilizer for a little while before they would start on any antidepressant medication. So the onset of lithium does take quite a bit of time. It's 7 to 10 days. And the therapeutic levels that we are generally looking at, especially in the active phase, is 0.6 to 1.2 milliequivalents per deciliter. So the blood level in the maintenance phase is a little bit lower. So if somebody's not in an acute manic episode, they can have a little bit lower levels, 0.4 to 1. But that 0.6 to 1.2 is what we really want to see if somebody is in an active manic phase. The blood draws are usually done 1 to 2 times a week for the first month or so, or until the level is stabilized, and then usually monthly after that, and then eventually every 3 months. And we usually want to draw that 8 to 12 hours after the last dose whenever possible. The typical dose is about 300 milligrams 3 to 4 times a day. So this is generally a medication that somebody has to take multiple times a day, which of course makes it more difficult for compliance. Also, as you know, lithium has a very narrow therapeutic range. So the blood levels between subtherapeutic and toxic are pretty narrow. And so this is why it's so important that we keep a very close eye on this medication and on the patient's blood levels. We don't want the patient to exceed 1.5 milliequivalents per deciliter. That's definitely that's getting toxic. And patients can actually start to have toxic symptoms even lower than that. So it depends on the person. So please make sure that you do know your advanced organizer information and understand what some of the different levels of toxicity are. It is helpful to ensure that you have an idea of what makes the different levels a little bit more specific. So if we look at, let me pull out the book here. If we look at what makes some of these a little bit different, if you're looking at different levels, so I'm on page 237 in the textbook. So you can see that even some of the expected side effects, so we can go from a fine hand tremor, polyuria, mild thirst, a little bit of nausea, general GI discomfort. So we do always give lithium with food. And some weight gain can happen right away. Now, when we start to have more vomiting, diarrhea, slurred speech. So when the patient starts to have slurred speech, that is definitely an indication that they're starting to become toxic. You'll see that they start to get a more coarse hand tremor. So it can go from real fine where you can just barely kind of see it to shaking, spilling coffee, that type of thing. And so we definitely, we're seeing mental confusion, anything like that. Those are definitely signs that we need to take intervention. So the biggest thing to make sure that we understand is that if the person starts to have some of these signs that we hold and we request a blood draw. So we're not going to continue to give the medication if the patient is home and they're calling in. We tell them the same thing. Don't take the next dose. You need to come into the office. They need to get a blood draw. And we have to go from there, see if they need to decrease their dosage for a little bit. Nursing interventions, watch out for those drug interactions. Lithium is one that can cause lots of different drug interactions, and they shouldn't be taking over-the-counter medications without consulting their physician or their physician's office, as well as diuretics tend to cause issues because it changes potentially the fluid and electrolyte balance in the body. So education, patients have to know what those toxic signs and symptoms are. They have to know when to call in to the doctor. They need to know that there are potential complications, that they will have to have annual kidney and thyroid tests done, and they have to report for those regular blood draws. They got to be compliant with that, or lithium is not the medication for them. They should watch their weight gain because it can be significant, and they should be taking their lithium with meals in order to help decrease that GI discomfort. Please understand that not toxic, just regular use of lithium can cause the kidney and thyroid dysfunction, so it needs to be assessed yearly. It can cause hypothyroidism and impair the kidney's ability to concentrate urine. Their diet, so hopefully this made sense to you when you read it. Their diet, they need to maintain a regular salt and fluid intake. So kind of their normal daily diet of sodium and fluids is what they need to continue to maintain after they're stabilized on the medication. So this is where if somebody's really ill and they're not able to take in fluids and things, especially if their sodium suddenly changes, their sodium level suddenly changes, this is where it can cause toxicity or subtherapeutic levels. So lithium acts like a salt in the body. So if somebody's suddenly decides that they want to go on a low salt diet and they decrease the amount of sodium that they're taking in, then the body will hold on to lithium more, and so that can cause them to go toxic. So we need to ensure that the patient understands not to change their salts, not to change their fluid intake, to keep it regular, and if they are really sick, they should be calling in to figure out how to regulate and probably increase their blood draws. Okay, so now the next type of medication we're going to talk about are anticonvulsants, and I tried to limit it to 3 that we really need to know some of the specifics on. So anticonvulsants, there's carbamazepine, Divalproex, or sometimes you'll also hear this called, it's Depakote or even valproic acid, and that one is a first-line treatment. There's lamotrigine, topiramate, oxcarbazepine. So the 3 that I really want you to know the most are Divalproex or valproic acid, and this one can cause weight gain, liver dysfunction, can prolong bleeding time, so the patient needs to be aware if they start to bruise really easy or have bleeding gums, things like that. The level for this is 50 to 100 micrograms per deciliter. So they should be getting that drawn on a regular basis and monitored. Lamotrigine, the biggest issue with lamotrigine, there's not a blood level for it, but the biggest issue with it is that it can cause a life-threatening rash called Stevens-Johnson syndrome. So the patient needs to know they need to report a rash right away if they have one. And then carbamazepine is one that can cause agranulocytosis or aplastic anemia. So again, the patient, you've learned about these conditions in med-surg. So the patient does need to watch for signs and symptoms of infection and report those. Also, it does have a blood level 6 to 8 milligrams per deciliter. Nursing interventions then are we educate the patient about their anticonvulsant medication, definitely monitor blood levels for those that have it. We need to make sure that they're medication compliant. They have to take these medications regularly because they are looking for those levels in the blood. As I mentioned, bruising, bleeding, monitor for that, as well as a rash. Don't stop these abruptly. They can also decrease oral contraceptive use, or contraceptive functioning. So patients need to know that they need to use a backup method. And they definitely should report any fever, sore throat, any signs or symptoms of infection. They should report that so we can make sure they're not suffering from the agranulocytosis. They also should avoid alcohol with these medications. Another class of medication that can be used with this, these are not considered monotherapy for bipolar disorder. There's something that are used as adjuvant medications, something to try to help kind of calm the patient when they're in an active phase and until the anticonvulsant, the atypical antipsychotic, or the lithium can take effect. So something that we sometimes use in patients short term is an anxiolytic. So clonazepam, lorazepam, these are benzodiazepines. And so they can help the patient with some of their psychomotor agitation, can help them calm down, hopefully get some rest. So just keep in mind that we don't usually want to use these in patients with a history of abuse because they do build up tolerance to these meds and they are addictive. Okay, so the third class of medications that we use as monotherapy are called atypical antipsychotics. We're going to learn a lot about these with schizophrenia. And so I'm just going to read a few of them. We're going to talk about them just in general. But olanzapine, risperidone, aripiprazole, ziprasidone, quetiapine, and then there's another one that you don't see as much. It's combination medication. I'm not quite as worried about that one. And there's a new one. So I'm going to spell it out for you. It's cariprazine, CARIPRAZINE. It's called Vraylar. You might have seen commercials for it recently, but it is approved as monotherapy in bipolar disorder for actually for manic episodes, depressed episodes, and mixed episodes. So this is one that I'm starting to see more and more. So these medications often, they're used kind of for two different things. So they can be used as monotherapy, usually given orally, so that the patient can just get started on them, get a, kind of get it in their system on a regular basis. And so that's going to then treat the bipolar disorder. However, we also use several of these medications as IM injections and use them because they have a sedating effect on the patient, can help them rest. We usually use these over the anxiolytics. So again, these can be used alone or in combination with lithium, often used in acute mania. But I do want you to understand, if you see these as an IM injection, they're more likely being used not as monotherapy for bipolar disorder, but more for their sedating effect so that the patient's behaviors and things can be safely controlled and the patient can rest. Other treatments, so we'll talk a little bit more next week about electroconvulsive therapy, but it can be used for patients who are rapid cyclers or very actively suicidal or are really not responding to anything else. Also, we want patients to go to support groups when they're more stable, and self-help groups and family therapy. As I've mentioned, family therapy helps to support the person as well as helps prevent relapse because they can help see those signs and symptoms that the condition is coming back earlier. Cognitive behavioral therapy helps the patient to accept the illness and need for treatment, which is sometimes really hard for people to understand. Helps with medication compliance or adherence, helps with early detection, intervention, and stress and lifestyle management. Some people's lives are completely upheaved with, bipolar disorder and the symptoms that go along with bipolar disorder. Evaluation, when we're checking to see how is the patient really doing after all of our interventions, it's have the hallucinations and delusions stopped? Is the patient safe? And can the patient function again in their different roles? So next, what I would like you to do is there is a case study for putting everything together. I would like you to work through the case study, and a little bit later today, I'll record another video going through it, but please don't, again, don't go through the video answers until you have worked on your answers first. All right, thanks.